All right, welcome back to part two. Hopefully, you had a nice restful break and we're able to keep calm and breathe in the air. But hey, we're back with part two. We're going to learn all about physiology and diseases of the respiratory system. Once again, I want to warn you there are some pictures of cadaver organs, mainly just lungs. But I just want to make sure that everyone knows about that before we begin. So let's do it. All right. So the first thing we're going to talk about is how we actually do ventilation. So how do we get that air into our lungs? And I think this is really cool. This is one of my favorite like physiological processes, just because when I learned about it, I was like, really, that's how that works. But negative pressure breathing is the process that we use to get air in and out of the lungs. So the weird thing about your lungs is that your lungs themselves don't actually do the pumping. They're the ones that do the gas exchange. So the actual pumping is done by the muscles of your chest that surround the lungs. And it also involves the pleural membrane as well. So basically, what we find out, and this is like a little bit of chemistry for you in case you forgot this stuff. The atmospheric air pressure at sea level is about 760 millimeters of mercury. So that's considered to be like our normal, default pressure that we're going to use to understand this. And so, what we basically do, because the pressure around us is pretty, constant throughout the day, is that we change the pressure of the air inside of our body to help to either draw air in or push air out. So basically, what you do is you change the size of your chest cavity or thoracic cavity to adjust its pressure. Because if you remember from chemistry that volume, pressure, and temperature are all related to each other through the gas laws. So if we increase the volume of our chest, we're going to drop the pressure. And because now we're creating a vacuum, it's going to suck air in. So basically, if you think about it, when you breathe in, you drop your diaphragm, you raise your chest, you expand your chest out and suck air in. And when you want to push air out, you raise your diaphragm and compress your chest and push the air out because you make the pressure higher. So basically, all we do is whatever the atmospheric pressure is, if we make the pressure around your lungs greater than, or I'm sorry, less than, less than 760 millimeters or whatever the atmospheric pressure is, you're going to inhale. So basically, you're going to create a vacuum. And when the pressure is higher than the atmospheric pressure, you're going to exhale because now the exterior acts as a vacuum. And so this is what this diagram is showing us. So here's us at rest. When we drop our diaphragm, it's going to increase the size of the pleural cavity and the chest cavity. And this is going to create a vacuum that's going to suck air down into the lungs and fill them up. When we push the diaphragm back up, it's going to cause the pressure inside your chest to increase above atmospheric pressure and push the air back out. And then wash, rinse, repeat. So this is it again, so you can see a little bit up closer. But basically, we're just adjusting the pressure by moving your diaphragm. So your diaphragm moves up and down. So when it comes down, it sucks air in, and when it goes up, it blows air out. And so for any of you guys that are into like singing or playing an instrument, you have to sit upright and have good posture. The reason being is if you hunch forward, you kind of compress your chest, and it makes it harder for you to suck air in. And so, like the better your posture is, the better, the easier it is for you to draw air, and that's really good. All right, so a couple properties of lungs that go along with this. First of all, your lungs are what we call compliant, and this means that they're able to stretch or distend themselves as pressure is applied. So if you take like the deepest breath you possibly can, you're like, what you're doing is you're stretching your lungs out by dropping that diaphragm, and the whole organ gets huge. On the other hand, when you breathe out, your lungs use elasticity to return to their original shape. So you stretch them with compliance when you're taking a big inhale, and then use that elasticity to kind of push some of the air out. So one of the things that I think is really interesting is that little kids sometimes will try to like hold their breath to get their way. They'll be like, I'm not going to breathe until you give me what I want. And the funny thing about this is that you can actually let them go. You can let little kids hold their breath all day. It doesn't matter because when you hold your breath, you're increasing the pressure. So you take air in and you're holding it in there. And as soon as you stop holding your breath, so like let's say I hold my breath as long as I can until I pass out. As soon as I pass out, because my muscles relax, all that air that I've stored in there that's full of carbon dioxide will come out of my lungs naturally following these physiological properties. And then my brain will actually subconsciously go back to breathing again. So you actually just breathe on your own without even trying. So it's really a pretty interesting little factor that goes in there. Anyway, so in addition to the diaphragm, there's a couple other muscles that we see that are involved with breathing. So the diaphragm is like your main breathing muscle. So it expands and contracts vertically. So it goes up and down within your chest cavity to increase the size of the chest. You also have these things called the intercostal muscles, and literally intercostal means in between the ribs. And you have two sets. You have an external and an internal set of intercostal muscles. The external intercostals are used to help you inhale. So when you take a deep breath, these things actually like pull your ribs apart. They spread your ribs. And when they spread your ribs, it actually increases the size of your chest. And if you ever take like a really, really deep breath, you can actually feel your chest cavity kind of like expand and your ribs spread. The internal intercostals do the opposite. They actually squeeze the ribs together and help you to forcefully exhale. So if you try to breathe and blow every little last bit of air out of your lungs, you would actually could feel your chest kind of like pulling together, and that's your internal intercostals. So it's kind of backwards if you want to remember this. So like the external are involved in inhaling, the internal are used in exhaling. There you go. By the way, if you guys like to eat ribs, these are the muscles that you're eating when you eat like spare ribs or baby back ribs or anything like that. You're actually eating intercostal muscles. So next time you look at some ribs, you can actually see these little guys in between the bones. And you also use a couple other muscles. You use your abs and your oblique to help you to drop your ribs when you're exhaling. So if you've ever exhaled really hard and felt like you were sucking in your gut and really like pulling your abdomen in, you actually are. So those muscles actually help to contract and compress the abdomen, which also helps to push up the diaphragm and helps you to squeeze more air out of your lungs. Great. And so this is just showing you that diagram. I didn't mention this in the notes, but just, if you want to know, if you remember your sternocleidomastoid, there's also these muscles called your scalene muscles. These are found in the neck. These can actually help you to lift your sternum and your ribs a little bit. So they can actually help you to take a deep breath. So if you ever feel like a strain in your neck when you're trying to breathe in really heavily, that's those muscles at work. So all this happens like subconsciously. But then you can see how these external intercostals are helping you inhale by lifting the ribs up. On the other side, and they're on both sides. They're just showing you this because the internal intercostals are actually just deep to the externals. But just for simplicity, we draw them on the other side. And you can see how these guys are involved in pulling the ribs down. Same thing where like our abs, when we're exhaling really hard, are going to pull the rib cage down. And our obliques are going to also help to slightly pull the ribs down. So basically, we have one set of muscles that are inhaling by lifting ribs, and we have a different set of muscles that are exhaling by dropping ribs. And they say the ribs kind of act like a bucket handle. So if you've ever had like a bucket or a pail and it has that handle on it, your ribs lift up, the front lifts, but the back stays put. And then when you drop your ribs, the front drops and the back stays put. So that's what they're trying to show you here is how these ribs, how they kind of come down. Like think about like a handle of a bucket, how they could raise and lower along with the sternum. And that's what they're showing you here. So this like kind of shadow diagram is when you inhale, you raise your ribs. And when you exhale, you lower your ribs. And same thing with the diaphragm. So when you inhale, you drop your diaphragm. So the idea is we're trying to make the volume bigger. So the ribs come up, diaphragm goes down, we have a giant chest. And then when we try to exhale, we raise the diaphragm and drop the ribs. All right. And so this is a graph. This is called a spirogram. And this is showing you basically how breathing works. So you have a certain amount of volume inside of your lungs. So normally when you're just naturally breathing, just sitting there, you take a little tiny breath and a little tiny exhale, a little tiny breath and exhale. And this is called your tidal volume. So this is like your regular breathing. When you take a really deep inhale, so let's say you try to inhale as much as you can. You suck all this air in and you can fill your lungs up. And the average person has about 6,000 milliliters of air that they can suck in. Okay, so that's like you're totally topped off your lungs. And then if you completely exhale, as hard as you can drop the air volume all the way down to about 1,000 milliliters. So there's some air that you just can't get out. It's just like kind of stuck in there because you can't like squeeze every little last bit out of your lungs. Once again, it's kind of like a sponge. All right. And so when you look at this, this is basically your max inhale, max exhale. This difference in here is what we call your vital capacity. So the average person has about 4,800 milliliters. So that's 4.8 liters, just to give you an idea. If you're thinking about this, if you think about like 2 liter bottles, that's like 2 liters and then 800 milliliters more that you could completely fill your lungs with. So if you did your deepest inhale and your deepest exhale on average, but most of your tidal volume, like your regular normal breathing, is only about 500 milliliters. So it's about a quarter of a 2 liter bottle is how much air you're sticking in and then dumping out. There's some other different things we can look at here. These aren't really that important, but there's this residual volume. This is the air that stays in your lung all the time. Now, obviously, it's not the same air, it changes over time, but there is a certain amount of air that you just kind of like trap in there that cannot be pushed out. The inspiratory capacity, that's how much from like your normal tidal volume you can inhale if you take a deep breath. Your total lung capacity, of course, is everything together. And the expiratory reserve volume would be like, let's say you were just breathing normally and you decided you were just going to blow all the air out of your lungs that you had in there that you could possibly blow out. That's how much you can exhale. So if I just said right now, like blow out a candle, you'd be like, and then take a deep breath and go back to your normal breathing. If I said take a really like the deepest deep breath you could take, you would take this deep breath and then exhale all the way out. That would be measuring your vital capacity. So these are just like little things we talk about, but not super, super important. All right. So the next little thing to talk about, that was everything we need to know about ventilation. Um, Gas exchange is where we look at the other two types of respiration, the external and internal respiration. So once we've gotten air into our lungs, this is what's going on inside of the alveoli is external respiration. This is where we're loading up on oxygen. So we're sucking oxygen out of our alveoli, out of the air that we've taken in and putting it into our blood, and then taking the carbon dioxide and getting it into the air. And so this is going between the blood and the alveoli and involves what are called partial pressures. This is a bunch of chemistry. But basically, if you look at the air going into your alveoli, the partial pressure of oxygen is about 150 millimeters of mercury. The blood that is coming into your lungs has a partial pressure of oxygen of about 40. So because we have higher partial pressure of oxygen in the air than in your deoxygenated blood, it's going to diffuse essentially from high to low concentrations. So external respiration just basically uses these partial pressures to push air from high to low concentration. If you look at CO2 concentrations at about 45 millimeters of mercury. In the air you breathe in, it's about 40. So it's a little bit lower out here. So once again, carbon dioxide is going to drop down. Once this goes back into your heart with the oxygenated blood, we can see now that our PO2 has turned to about 100 millimeters of mercury. So we've sucked some of it out and we've gone from about 40 when it was going to the lungs up to 100. Our carbon dioxide went from 45 down to 40. So carbon dioxide doesn't change that much, but oxygen does. The oxygen, then we take it down, the oxygenated blood, we send it into our capillaries and our tissues. And this is where we do internal respiration, where we're going to load carbon dioxide and unload CO or unload oxygen. So here's where we're going to see this PO2 of 100 versus our tissues that have about a PO2 of 40. So obviously, this is going to go down its concentration gradient from 100 to 40, and we're going to dump off oxygen. At the same time, we see carbon dioxide here is 40 in the blood, and in the tissues, it's about 45. So we're going to do a quick exchange. And so when it comes back out, we've increased its carbon dioxide load. So basically, as long as there's more oxygen in the air you breathe than there is in the blood that's going to your lungs, you will always pick up oxygen. As long as there's more oxygen in the blood, as it goes down into your capillaries, it'll get dumped into your capillaries. And then same thing for carbon dioxide. As long as there's more carbon dioxide in your tissues than the blood, it'll get dumped into your blood. It'll get pumped to the lungs. And as long as there's more carbon dioxide in the blood than there is in the air, it'll get dumped out. So as long as these things are true, all of this respiration works and gas exchange works, and you can stay alive and be healthy. All right, so a few things about how we regulate breathing. There's this little thing called eupnea, and eupnea is what we call like our regular quiet breathing. So if you're like not thinking about your breathing and you're just taking little inhales, little exhales, and not even thinking about it, that is called eupnea. We generally stick with this as long as we're just kind of at rest and we're not exerting ourselves. If you need to, you can consciously control your breathing. So your conscious part of your cerebral cortex can take over and either stop you from breathing so you can hold your breath, or you can like start to hyper ventilate yourself by overinflating your lungs. So if you decide you just want to take a whole bunch of deep breaths, you can do it. Anyway, but that's always possible. So like there's always the possibility of doing conscious control of breathing, but for the most part we don't. It's just unconscious. And there's this thing called the inflation reflex, which basically means that inside of your brain, in the medulla, in the aorta, and then in your carotid arteries, we have these chemoreceptors, and their job is to keep an eye on like the gas level. So they look at how much carbon dioxide, how much oxygen, and how many hydrogen ions for pH are in your blood. And then they send this information to your medullary rhythmicity center in the medulla, and then it's going to change the rate and the amount of breathing. So, like as you start to run low on oxygen, it makes you breathe faster, it makes you take deeper breaths so that you can maintain your proper respiration levels. And so this is showing you this graph where we have all these different, and this is way more detailed than what I went through. But basically, you have this inspiratory area, which is going to look into normal quiet breathing. And it's going to basically trigger the diaphragm and the external intercostals to contract and produce breathing, and then cause them to relax to allow your lungs to recoil or bounce back. When your inspiratory area is active, you can start turning it on to increase the amount of contraction of these muscles and have harder inhalation. And you can start to turn on the internal intercostals and the abs to cause forceful exhalation. So this is like when you're breathing heavily versus when you're breathing lightly. And this is just showing a little feedback loop showing you of how this all works with homeostasis. And basically, we just have all sorts of information going in, looking at your arterial PCO2 and PO2. So looking at the partial pressures of these two things. Mostly we look at carbon dioxide. So if your carbon dioxide levels get too high, this is what we actually look at more than oxygen in your body. So it's going to send this information to these receptors inside your brain and in your blood vessels are going to send this information to that medullary rhythmicity center. It's going to turn on those muscles that control your breathing. And then once everything goes back to normal, we kick this off. All right, so that brings us to the diseases and disorders of the respiratory system. First one is called pneumothorax. And so anytime something has like pneumo in it, we're talking about air, like a pneumatic system. So literally, pneumothorax means that you have air trapped inside your thorax, particularly in the pleural space. My neighbor actually got this. He has a quad. He was out riding and he flipped it. And when he flipped the quad, I think it landed on him and he broke his rib. And his rib actually punctured his pleural cavity, and he actually got air from outside into it, and it caused his lung to collapse. So usually when people get pneumothorax, because the pressure is usually like a slight vacuum around your lungs, it causes the lung to kind of like constrict down, and they actually have to pump the air out. So if you've ever heard about them sucking air out of someone's chest to restore their breathing function, that's what it is. And I can actually show you, here's a picture of someone who had pneumothorax. Under x-ray, your lung, because it's such a like soft spongy organ, should look pretty much black. Here, this one has had a collapsed lung, so the whole thing's kind of like squished down, and they have to suck the air back out to to get back to having the vacuum that it should have. Ateltac, I can't even say this. Um, Atelectasis, wow, oof, is where you have a collapsed lung. So that's actually like the result of pneumothorax. COPD, this is something that you've probably heard about a lot, is chronic obstructive pulmonary disorder. And this is a disorder where you have two different things that kind of go hand in hand: chronic bronchitis, which is where your bronchi become inflamed, and emphysema. So these two things kind of go together. You can have them separately, but usually they're found together in COPD. And emphysema is where your lungs start to become damaged from a lot of like dust, dirt, or of course smoking particles that go in and destroy the elasticity of the lungs. So the lungs start to become like scarified in emphysema and damage the alveoli. So let's take a look at that. Oops, had this out of order. Okay, here we go. This is an actual lung with emphysema. And so in this case, here's your normal healthy lung that have all these nice little tiny alveoli. From chronic smoking and dust, the alveoli start to collapse and cause these like big pockets to form that are damaged. And that's what we're seeing here. All this kind of like nasty, like beige stuff is where we used to have alveoli and they've just disappeared. We were actually able to open this lung up and it's like one giant hollow pocket. And what's interesting about this is that when you breathe, because mostly we just breathe using our tidal volume and it's a small amount, it's usually the top one third, like the top lobe of the lung is usually where we see this, and it becomes just like caved in on itself. It's horrible. A lot of smokers struggle with this, especially as they get older. And that's when you see people that have to take oxygen that are former smokers. The last one is called asthma, and you've probably heard of this before. And this is just an allergic constriction of the bronchioles. Usually it's allergic, it can be caused by a couple other things. So basically, if you have asthma, normally your airways are open and everything's good to go. And you can see there's a nice, like, wide diameter. When people have asthma attacks, here's what happens is inside of the walls of these bronchioles, we see that there is this little layer of lamina propria, which is very similar to our blood vessels. And there's a few mast cells in here. In people with asthma, they develop a whole bunch of mast cells, macrophages, and other white blood cells that are looking for a response to something. So, like, for example, some people have asthma that's triggered by certain allergens. And so when those allergens are present, they cause a ton of inflammation and a buildup of mucus. And so that inflammation and mucus kind of blocks off the airways and they can't get air into the alveoli. And basically, asthma is where your body is reacting over something that it shouldn't, like some sort of like allergen. Some people from exercise induced asthma, just like, when they start breathing heavily from exercise, their airways clog up like this and they can barely get the air in. So what do? All those little asthma treatments that they use, like inhalers, for example, basically go in and either calm down this response through steroids. Sometimes they use epinephrine, another thing that they can use. There's a whole bunch of different drugs that'll cause this allergic response to calm down and allow you to breathe again. Here is a lung that has lung cancer, and this is pretty gross. Looking at an X-ray, you can see there's this kind of like these like cloudy looking areas that should not be present. You can see them here too. And that's what they're looking at is all these little white dots here are tumors. So those are individual tumor cells that have formed on this lung. This is a lung with carbon deposits. These are really common in older lungs because of all the smoke and smog in Pittsburgh, but smokers get these too. So all these little like black little lines in here, these are all just different areas where like carbon has built up from smoke and soot and all that kind of stuff. And it's pretty nasty. So that's what we would call like the old black lung, essentially. And there's emphysema, of course. All right. Well, hey, thanks for listening. Hopefully you guys learned a lot about the respiratory system, and we'll catch you next time.